tell me when you're good for me to go. Yeah.
Anytime now, that'd be good.
Okay, great. So hi everyone again. So this week I've managed to sort out my technology a little bit because I've got two screens up, so I can sort of see the chat at the same time. If anyone does have questions or wants to say anything during the presentation, I can see it now. So this week I've got prescribing analgesia in the elderly, sort of the do's and the don'ts. I have to slightly apologise to begin with because this week has been incredibly busy and the slides probably are just not as good as I wanted them to be, but hopefully it's still useful and you can weed out the good information out of some of the maybe slightly busier slides than they were last week. So the first thing that we're going to do again is the plan of what we're going to do. So initially just a little bit about the analgesic ladder. Considerations about prescribing analgesia and how unhelpful the guidelines are for the older population sometimes because they just don't necessarily apply. Just a little bit about the different types of pain because it can affect what you're prescribing, sorry. And then a little bit, which I think is really important in the older population, is actually a little bit about deprescribing. For especially sometimes in patients who have pain and analgesia and trying to optimize what they have better. And then I do have a few case discussions at the end. I appreciate that some of you are on nights, so please don't worry if you don't want to sort of answer anything or put anything out. I can talk myself if there isn't any sort of answers. So the first thing is just to go through a little bit about the WHO analgesic ladder, which I know probably a lot of people are aware of. But when I was sort of the first thing I think about when I think about prescribing analgesia is this, but actually I didn't really realise how out of date it is. And also that it wasn't really formed thinking about sort of either acute pain or chronic pain. So apparently it was set up in 1986, and actually it's been validated as a tool for improving treatment of cancer pain, which is technically a different type of pain compared to chronic and acute pain and neuropathic pain. And it talks about sort of using non-opioid medication for mild, then for moderate weak opioids, then for severe strong opioids, and adding in adjuncts as we go through that as well, and working in a stepwise manner. So I think generally the approach is probably good, but I think it is somewhat outdated. And also in older people, we would not necessarily, we may think about jumping some of those steps depending on what type of pain it is. The other sort of guidelines that I looked at were the NICE guidelines. And again, they were quite unhelpful for thinking about older population and older people. So again, the mild to moderate pain, they talk about paracetamol, they talk about NSAIDs, which we do try and avoid in older people. They talk about aspirin, which we don't tend to use as an analgesic agent in older population, and then about weak opioids, but then including tramadol in that, which I guess we would also try to avoid. It then talks about how you would use a stepwise strategy, I guess, sort of applying the WHO analgesic ladder. But in particular, they sort of talk about starting paracetamol, but then if that gets to its optimum dose, substituting it with an NSAID or a weak opiate, which again, we wouldn't necessarily do. I think that if you've got to the top dose of paracetamol, I don't know why you'd be stopping it to add something else in, because we know that it can work really nicely as an adjunct to other pain relief. And again, it talks about using ibuprofen a lot, which we tend not to use in the older population, which I will go into in a little bit. So it talks about when prescribing analgesics, which I think this bottom bit is quite helpful for considering what you're doing when you're prescribing. So it talks about using a full therapeutic dose of another before moving on. It says about switching, which I potentially wouldn't do. And then it talks about making sure that you're looking at what the underlying cause of the pain is, because that's going to decide potentially what agent you're going to use. And then also doing a full clinical assessment of that patient, and always reviewing essentially what you're prescribing. So this is just a little bit about the limitations, which we've sort of already gone through, really. So why the analgesic ladder is potentially unhelpful for persistent pain and chronic pain. So in particular, chronic pain is quite unpredictable. They talk about a lot that there is different reasons for the pain. It's not just necessarily one cause. So you might need to think about how your approach to treatment differs. It talks about the fact that when you self-report pain, it obviously varies from person to person, and the intensity of pain can change depending on what the situation is at the time, and how sort of emotions and thoughts and distress can affect that. So it then talks about the stepped approach and saying that, again, you need to be a bit careful of how people self-report pain and how you're going up that analgesic ladder. Medication should be used along with non-pharmacological measures, so things like physiotherapy or even like meditation or mindfulness, that sort of thing, or acupuncture. I think that's quite a good one. And then trials of both weak and strong opiates can be considered, essentially, if the first line symptoms don't work as they should do, and also to just continue to review. And I think that's one of the main things in medications with older people, is continuing to review what's going on, because the main thing you don't want is their medication list to be building with all those side effects that can occur. So a little bit of types of pain, which I'm sure probably all of you are aware of. So it's just thinking about how they may differ. So in particular, acute pain can be severe. It's normally short-lived and can be sometimes fairly straightforward to treat, because you start with your simple analgesics and potentially work your way up. I think the other thing to consider is that you might be able to go for a stronger medication like an opiate, or even something that might have side effects, because you know it's only going to be for a short period of time, and it can be stopped, and those side effects might not come into fruition. With chronic pain, it's thinking about the other things that it may cause. So it could affect sleep, it could affect mobility or mood, and thinking about how maybe other non-drug treatments can help from that side of things. Apparently medications generally, I think they only work for, I think they said, less than a third of patients with chronic pain, and it's helping to understand the patient to understand their pain is sort of probably more empowering than medication a lot of the time. Neuropathic pain, we know, is to do with injury to the nerves or the nervous system, and we may pick other medications apart from our normal sort of simple analgesias to combat those. So it's good to get the history to know whether that is the cause. Again, I think these medications can be pretty. It depends from patient to patient how well they help, and also thinking about. If one doesn't work, you might need to stop it and try another one. But I think in the older population, that's probably a bit riskier than in a younger person. And then cancer pain, which can be from tissue damage or nerve damage, can be acute or chronic. So probably is a bit more complex in general. So the key points from the NICE guidelines was that acute pain is a body's normal response to tissue damage, and that can be treated probably a little bit more simpler. Cancer pains can be from tissue damage or nerve compression, but persistent non-cancer pain, you need to think about other sort of factors that may be influencing the tissue injury that is there. They're talking about a trial period of opiates, and then making sure that that is reviewed and whether it needs to continue, and that side effects need to be balanced against the potential benefits. So it's all about talking to your patients as well, if they're able to join in that conversation. And if medications don't give sufficient analgesia, then consider whether it is working, because it's that risk of dose escalation, which we see often in older people and then causes multiple side effects. So this is considerations in older people. So when you're thinking about starting prescribing, it's thinking about where the pain is and what is causing the pain, because that might influence what you're going to prescribe. What type of pain is it? In the older person, we have to think about their weight a lot, because frailer people may have a lower body weight or low muscle mass, which then may affect the dosing of what you're using. You have to think about the liver function, the renal function, because often even, you know, someone who's quite a well-functioning older person may have a degree of renal impairment. And then other common presentations to think about are whether they've got delirium and how that might be exacerbated by what you're about to prescribe, or whether they're at risk of delirium. Constipation is such a big thing within the older population, especially in hospital, and how are we going to help from that side of things and potentially hinder dehydration and acute kidney injury are things that a lot of our older population present with or have, and things like NSAIDs can really affect or exacerbate someone who is maybe mildly dehydrated, will then develop an AKI. Urinary retention, so those are things that have like an anticholinergic burden, such as amitriptyline, can really affect, can potentially put into urinary retention. And then also just thinking about the tablet burden and the non-compliance of people with their analgesia, and how we can tackle that in the older person, and what we're prescribing, is that going to be complied with and in effect help. So I was just going to go through a few of the medications that that everyone commonly prescribes, and how it may affect people in the older population. I mean, paracetamol, I think everyone is aware of here, that obviously if it's less than 50 kilograms, then you need to think about reducing the dose to 500 QDS. And I always think that it's worth prescribing regular for anyone who has come in with any sort of element of pain. But I guess it's sort of going back to that, ensuring that there is a review date on paracetamol, because I can imagine the amount of older people that are just on regular paracetamol for the rest of their lives, essentially, because it's just not reviewed. And I'm probably just as guilty as anyone of that, that it's there to help and it makes them feel better while they're in hospital and feeling poorly, but actually they probably don't need to be on it at home. So NSAIDs, so we tend to avoid using this in the older person. So the reason is that for people who already have reduced sort of renal function, or at risk of reducing their reduced renal function, it causes reduced blood flow through the kidneys, and then you're going to develop an AKI associated with that. The other reason is because of GI irritation, and it reduces the production of things that protect against gastric acid, so you're at higher risk of bleeding. So in the BNF, in particular, it states, it has a whole section on NSAIDs in the older person, which is what I've put underneath. But it doesn't say not to give them. So in particular, it talks about the fact that older people are at higher risk of associated bleeds, but also in people who have cardiac disease and renal impairment, older people are at particular risk if you use an NSAID. Then it sort of gives sort of how to manage osteoarthritis or back pain underneath, or even rheumatoid arthritis, and initially thinking about sort of non-pharmacological interventions, but then thinking about using paracetamol first. But then they do suggest adding in a low dose NSAID, which I just wouldn't do first line. It would always be assessing the person in front of me, but most older, frail people, I wouldn't start them on NSAIDs. If I had someone who, you know, maybe was in their late 70s, even early 80s, I guess, and had no medical problems, their kidneys were plumb normal, and this is the first time they've come to hospital because of something, you know, unrelated to their kidneys or their stomach, and they say had like an inflammatory arthropathy, which was acute, I might consider giving them an ibuprofen, but it would literally be for 5 days, and it would have a stop date on it. It wouldn't, on Lorenzo, I wouldn't prescribe it any longer than that. And that's just because of the risk of these in the older person. Always think about putting a PPI with them, which I think it says at the bottom of that section in the BNF. Yeah, I would very much sort of advise them not to continue taking it at home. The same way that if I was discharging them because they probably didn't need to be in hospital if they were that well, yeah, I would make sure that, again, it was only a 5-day supply and they wouldn't go and buy it over the counter afterwards. And if it doesn't improve, then they need to see their GP, because the last thing I want is for them to have prolonged NSAID exposure. So then going on to weak opiates, which I've mainly focused on codeine here. So in particular, I think the main thing, if you are going to start codeine, which I think is perfectly reasonable in an older person who is already on regular paracetamol, and maybe has sort of some ongoing chronic pain that's not being controlled, I would make sure that we're starting low. I guess if their body weight is under 50 kilograms, I would think about maybe those 500 cocodamols, because you're only using one of them, and then it's 8 milligrams of codeine and 500 milligrams of paracetamol. And depending on the pain and what they need, you could consider giving it regular, so 15 milligrams regularly, plus maybe 15 milligrams breakthrough if they need it alongside it. So contraindications are a lot of bowel stuff, but in particular, I just wanted to point out that in the cautions, and this is for all opiates, it does state that in elderly you need to consider a reduced dose. So that's, again, in the BNF. For liver and renal impairment, again, it sort of says that you might need to consider dose adjustment, but for severe hepatic impairment, they suggest to avoid it. And I would assume that's because of the risk of encephalopathy alongside using opiates. And then in renal impairment, again, it's saying to avoid or reduce the dose. I've just put a big red sign over tramadol. In the older person, just don't use it. You've got so many other choices, so just don't. I've recently had a patient that was on orthogeriatrics that came from orthopedics on tramadol, and they came to me and asked me why he was confused. So just don't. Strong opiates. So these are probably the 4 that we think about. So we've got all our morphine sulfate preparations, oxycodone, in particular those who have renal impairment. You may see fentanyl patches around, and then in particular buprenorphine or butrans patches. We do tend to prefer butrans patches in the older population, I think, because the lowest dose of 5 micrograms is a lower starting point of morphine, equivalent morphine, than fentanyl. So I did write this down so I remembered. So 5 micrograms of buprenorphine, different places tell you different things, but it's roughly sort of about 9 to 14 milligrams of morphine, where a 12 microgram patch of fentanyl is about 30 milligrams of morphine. So it's quite a big difference. So we do prefer to start butrans because it's lower dose, and also it's kinder on the kidneys, we find, as well. So it's also, in all opiates, this includes codeine, it's also something that you have to consider in the STOP criteria, which I mentioned last week as well. So it's a screening tool of medications that you might need to think about whether it's an appropriate prescription. So they're saying that they should not be prescribed essentially as a first-line therapy for mild pain. So if it's been prescribed as that, then you need to think about stopping it and doing something else. If it's used regularly and a laxative isn't prescribed alongside it, that's a reason to potentially stop it, or I guess introduce a laxative. And then again, if you're prescribing a long-acting morphine without short-acting breakthrough. So again, if you've got regular analgesia, you should always think about what happens if this person has more pain. So what are they going to use on their PRN side? So whenever someone's on anything regularly, there should always be something as a rescue remedy for them, PRN. And then again, this is just, again, which I'm sure most of you are, about cautions to use in opiates. But I think the thing in particular is as many, how many of these things happen for older people who come in particular head injuries. So we should always be thinking about whether it's appropriate or not. So these are side effects of opiates, which I think are probably some of the most common ones, but definitely not all of them. So again, it's just thinking about how all of these things can affect the older person, and especially those people who can't communicate their needs to us as well. If they've got constant itching, just how distressing that might be. And thinking about, again, how sort of prescribing, you're going to have a rapid escalation of prescribing as you try and counteract all these side effects, essentially. I think it's one of these things that morphine is one of these things that we probably do use more in the older person, but it's also being cautious with it. So a little bit about neuralgic medications. So these are the 4 that are normally talked about when you think about it. Amitriptyline we tend not to in the elderly. So again, we're thinking about this sort of the anticholinergic burden, so the risk of urinary retention and confusion associated with amitriptyline. However, you will see a lot of older people come in on amitriptyline at night. I can't say I necessarily cross them all off, but it's just something that we should be reviewing. Duloxetine we're mainly using diabetic neuropathy, so peripheral neuropathy patients for that reason. Gabapentin and pregabalin are probably the 2 that if someone's got neuropathic pain to maybe consider starting. So in the BNF, for all neuropathic pains except for trigeminal neuralgia, it rules out that you should consider a choice of amitriptyline, duloxetine, gabapentin, or pregabalin. But again, it doesn't specify, is this for a younger person or an older person? So again, in my opinion, look maybe more towards your gabapentins and your pregabalins for older people. They suggest that if it's not effective, then think about trying one of the other ones. But again, I think that's something that you just need to be very cautious about in an older person, about weaning them down and restarting them. Because if they're already on a high-ish dose, you shouldn't just stop these medications straight. You should be weaning them down and then starting another one afterwards. They say about considering tramadol, which I would completely disagree with. And then they also say about consider capsaicin cream, which I asked my husband about because he's a GP, because I've never prescribed it. And he says that apparently it doesn't really work, is essentially what he said. It doesn't have much evidence behind it, but he sometimes uses it for people who have like post-hepatic neuralgia to try and help from that side of things. But as I say, I've never used it myself. So gabapentin, this is what the dosing suggests in the BNF. For an older person, I'd probably go for the top option because it starts you at a lower dose. And I think that's probably the safer way to go for an older person. And I wouldn't be escalating necessarily to the heights of, sort of 900 milligrams 3 times a day, which you can give. It does state to be cautious in the elderly. And there are dose adjustments in renal impairment, but it does state that it's got a low anticholinergic burden, which is why it's probably better than amitriptyline to use. Again, it's just like the range of these are the common side effects in the BNF, not even the uncommon or the rare. I didn't put those in. So again, it just shows the range and how those could affect an older person. So confusion, cognitive impairment, visual impairment, think about the falls that this could potentially cause, gait abnormality. So I think when you are starting these medications, it's difficult out of hours for you guys because you're trying to do something when someone is in pain. But I think it's about thinking about trying to have that conversation with someone about whether there are side effects associated, but we'll try it low and try and wean it up if we can. Pregabalin, so I'd probably start at 75 twice a day, even lower, maybe 50 twice a day for an older person, but I'd definitely start at the lower end of the range. And then titrate up. And again, I wouldn't be going to the dizzy heights of probably 600 milligrams daily. And again, you can see again all the side effects. Again, these are the common ones. And then constipation was one of the main ones that came out for pregabalin in the older population. And there is again a renal dose adjustment, so just to be wary of. If you need to prescribe it, just think about their renal function. So then my medical student this week, we had someone come in on nefapam, which I haven't seen for a while. And he asked me about it because he hadn't heard of it. And I remember when this was really popular. So the BNF still states it's for moderate pain. And initially to use 60 milligrams unless you're older. So they suggest 30 milligrams for older people. I think it says caution in the elderly. And in renal impairment and urinary retention. So I think those are probably all things that we just don't really use it in older people anymore. So yeah, as I say, I haven't seen it for a while. But also don't use it for anyone who's ever had a seizure. And I think one of the main side effects I've seen with nefapam is normally hallucinations and confusion in the older person when we were using it before. So generally not used, but probably just to be aware of. And then there's always the lidocaine patch, which when I looked into this, it's only licensed actually for post-hepatic neuralgia, which I didn't realise, because I feel like sometimes we sort of stick it on as a last resort for people who are in pain. But actually, our CCG doesn't support the use of prescribing lidocaine patches for post-hepatic neuralgia, and it doesn't, as in, unless there are alternative treatments that have been proved ineffective. But even so, they just don't really like it, it seems, the CCG here. So I don't think they would fund it. And they just stated that the evidence is unclear for it. So the other thing to always think about is nerve blocks. And I'm sorry that I don't really have much more information on this, because it's something that I haven't really got that much experience in. But in particular, for people who've got acute pain who are older, nerve blocks are normally actually a lot safer than opiates and other medications that we would use for that, to get them over that initial phase. And I know that there is that option when you speak to the acute pain team. I think there are anaesthetists that will come and potentially consider blocks, especially for things like rib fractures. The other time that I've seen nerve blocks used a bit more is, again, in pain for palliative care. And I just think sometimes it's things that, because we don't know a lot about, and I don't either, so it's something even for me to think about, and maybe learn a bit more about. It's something just to consider, that whether nerve blocks would be better if someone is really not tolerating their opiates, and they're getting a lot of side effects, or there's a high risk of using opiates if they're in acute severe pain, whether a nerve block is something that we should be thinking about. So I just wanted to talk a little bit about deprescribing, because I just think it's so important in the older person. And I think when you think about deprescribing, you also think about what you are going to prescribe. So it just helps your mindset. So this is the link, which when I send these slides out, will obviously be on the slides that you can use. And it was presented in a trainees weekend that I went to for geriatric medicine, and I think it's quite a useful document, and it's got some really nice case studies at the end about deprescribing in older people, because it's just sort of stating that a lot of people have preventable admissions because they have polypharmacy and adverse reactions secondary to that. So when we are prescribing, we should be thinking about whether it is appropriate and whether there's anything actually that we can stop, maybe to counteract what we are prescribing. So this is I've just lifted these from the document. So it's about polypharmacy and thinking about whether it's the right medication, whether it's unnecessary, whether it's going to have an effect, what are the risks associated with it. They talk a bit more about cost effectiveness, which I won't in regards to analgesia, because I think there are probably other medications like bisphosphonates that are maybe more in that category. But then in particular, making sure that we're agreeing and sharing the plan with the patient or their relatives. And then on the side, it sort of talks through sort of going through through 7 steps about identifying what is important to the patient, what you're trying to achieve, when should we review the drug, what are the symptoms we're trying to control, what are the risks associated with the drug, and going through it. So I think it is worth a read. Then this, which hasn't really come up very well on the screen, but essentially, again, is just going through the different steps. So it highlights in particular certain groups of medications that are either have a lot of side effects associated with it. So those ones you need to consider. Maybe those ones aren't as cost effective. So it's just highlighting certain medications. And NSAIDs and opiates come up quite a lot in it, which you would expect, especially in the potentially side effect and unnecessary drug therapy. This table, again, goes through the different sections of the BNF, and down here is where there are opiates, and then at the bottom there are NSAIDs. In 4 and 10, and if you go across the top, it just talks about the cumulative burden that these medications cause. So it could be to do with respiratory problems or bleeding, etc., and where they will accumulate to cause that high burden, essentially. So again, it's just something to have a look at when you look at the document. And again, this is just pulled out because they go through the different medications as well and why you would be cautious about using them in the older person. So you can see at the top that it talks about opiates and in particular constipation. So you need to use laxatives, and then again in cognitive impairment and maybe respiratory depression. Paracetamol, it talks about reducing the dose for the weight. And then with NSAIDs, again, it says caution in using for anyone over the age of 75 or if you have cardiovascular risk factors or renal risk factors. So again, it's being very cautious of these medications in the older population. So I do have a few case discussions. Probably if any, I don't know if you guys can all use the chat or if you're on your phones, but if you do want to write in the chat if you've got any thoughts. Otherwise, I can just talk you through sort of what my thought processes behind them is, because ultimately there isn't really a definite right answer for a lot of these. It's very dependent on the patient that's in front of you and what you're comfortable prescribing. So a lot of the time there isn't a right answer. So the first one, these are all very basic, by the way, as well. These cases, there's not that much information on them. So the 83-year-old lady who has come in with a hot, red and inflamed knee. We've done an X-ray, maybe I've done an aspirate, and we've decided that this is pseudo gout. But when we've looked a little bit more into it, we can see that she's got a CKD4, so she's got a very high creatinine of 254, but that's normal for her. So really it's thinking about what considerations do we need to take in to then decide what we're going to prescribe for this person. So if you have got chat and want to write anything, do. Otherwise, I'm just going to keep talking. So essentially, the first things that you think about is looking at what she's on already. So what pain relief is she on already for this? Essentially, pseudo gout should be an acute pain. So it's something that she will hopefully recover from in, so many days as the inflammation resolves. So it's not something that hopefully it won't last for a long time. What else did I think about for this? Thinking about the fact that she's got renal function is impaired, so that's going to limit potentially what you can pick. And then I haven't given you much information, so it's thinking about, has she got delirium? Is she at risk of falls? What's her body weight? So all those sort of things to take into account. So the first thing that I prescribe, because ultimately if she's not on any pain relief at all, the first thing that I would think about is prescribing regular paracetamol for this person. With a review date on it, in a week's time or so, to make sure that she's not on it forever. And if her weight's okay, then that'd be a gram QDS. Because this is an inflammatory pain, it might help somewhat paracetamol, but might not help completely. So the other thing to think about is then what anti-inflammatory medication might you prescribe. Now, with that renal function, NSAIDs are pretty much out the window. Now, if she had a normal renal function and didn't have any other medical problems, because this is an acute pain that could improve after a very short course, ibuprofen gel is probably quite a good idea, Nazia. I guess even with that renal function, there is a risk of absorption with ibuprofen gel, so I would be cautious with it. And I don't know how effective, like numbers needed to treat wise. It's worth a go and see whether she improves with it. But I would be cautious with the creatinine still. So normally in these situations, we actually think about using prednisolone, so steroids, at a low dose because people tend to tolerate it. But again, if she had delirium already, you have to be careful with sort of deliriums associated with steroids as well. If she was diabetic, you'd be worried about her blood sugars. So there are always risks associated with the things. I think it's about 10 to 20 milligrams. So it's quite a lowish dose of pred that you use for pseudo gout. So it probably, weighing at the risks and benefits, probably that might be okay for her. And again, you'd only give it for, say, 5 days, and I would just stop it and then get someone to review it. But they should improve after a few days. The other thing you could consider would be codeine. But again, with that renal impairment, I would be very, very, very wary about prescribing codeine. But I guess, again, for a short period of time, for 5 days, you would hope that it wouldn't, at a low dose, it wouldn't build up in the system. But codeine wouldn't necessarily help with the inflammatory aspects of it. Okay, so the second case, another 83-year-old lady. So she had a fall, her legs gave way, and she's got pain in her hips on movement and maybe a bit more so on one leg, which is the leg she landed on. So the x-ray is showing osteoarthritis. There's no fracture for this lady. She's got a better renal function, so CKD is 3, but she does suffer from constipation, delirium. So again, thinking about what we're going to do for this lady. So this is probably more of a chronic type pain, even though there might be an acute element to it, which has exacerbated her pain. And then if she's not moved afterwards, that's going to make her chronic pain a bit worse. But I guess the things to think about is over time, as she does get back on her feet after that initial sort of pain relief and getting her back on her legs, that pain could improve. So this is why it's so important to make sure that pain analgesia is reviewed in older people, because again, if you start something maybe a little bit stronger for this person, you don't want to be prescribing it for a long time. You need it reviewed in maybe in 2 weeks' time, even a month's time, but just some time that someone can say, okay, yes, her mobility is better because she's moving better, her osteoarthritis is better. So again, we don't know what else she's on. She might already be on medication. I'm going to say that she isn't, essentially. We have to think about her weight again and the fact that she's already fallen. So she is at risk of fall. So we need to think when we are prescribing things to think about the risk of falls associated with that. So again, I would have this, because she's got chronic pain, I would be thinking about having this lady on regular paracetamol with some maybe breakthrough codeine to begin with, again at a low dose, because of the constipation delirium, with some laxatives. And then if that wasn't working, you might think about adding in it regularly with some breakthrough elements, so only 15 milligrams QDS. But even with that, if you think about a Butrans patch only being sort of 5 micrograms is about 9 to 14 milligrams of morphine, 60 milligrams of codeine in a day, so 15 QDS, is already 6 milligrams of morphine. So it's not far off the lowest dose of Butrans. And Butrans is a bit better for your bowels. It's a bit better for delirium. It's a bit better for your kidneys than codeine. So actually, it wouldn't be wrong, even though people I think are a bit worried about starting patches straight off when they haven't been on an opiate. I don't think it would be incorrect if you could justify your decision behind it. And as I say, 5 micrograms of buprenorphine is actually quite, it's on the lower side of morphine, the amount of morphine in 24 hours. If you are prescribing a buprenorphine patch, though, you do need to think about your breakthrough pain. So you might want to prescribe a very, very small low dose of Oromorph to go alongside it, because it should be about 1/6 of the regular morphine that they're having. So actually, it's probably only 2.5, probably less than that really, but probably you want to go for the 2.5 milligram of Oromorph as your breakthrough pain for someone who's only on a low dose of buprenorphine. And yeah, we just need to make sure that that we've prescribed laxatives for this patient, and making sure that we're monitoring their bowels. And again, as this person gets on and is walking, that patch might not need to stay on. So again, you want to make sure that it's stated in the discharge letter to the GP that this patch might not need to stay in place and could potentially be removed at some point. So case 3. So I've got an 88-year-old gentleman this time who's got back pain and it's degenerative features on his x-ray, and he's already on medication, so he's on paracetamol, codeine and Oromorph, and he's used 30 milligrams of Oromorph in the last 24 hours. So I think, I don't know where else I'll put this. Oh, so he's got a creatinine of 134 and he's actually got a lowish body weight. So even though the creatinine doesn't seem that high, I think we need to think about the creatinine clearance associated with this because of his body weight. He's got constipation, as they all do. So I think that's one thing to work out, is the creatinine clearance, to think about what you're using. I think automatically when you look at that, I think alarm bells are being raised. That he's on a gram of paracetamol, so that needs to be reduced. He's on codeine with a pretty bad creatinine clearance, and he's constipated, which is probably not ideal. And then he's on morphine sulfate, which we know that someone with a lower creatinine clearance, we actually want to think about oxycodone instead for people with EGFRs under 30. So there's probably a lot of things to think about when changing the medication for this patient. So we need to reduce the paracetamol to begin with. We probably need to check their LFTs to make sure that paracetamol hasn't done any harm as well. And then we need to think about what we're going to do with this codeine and Oromorph. In my opinion, this patient probably should be on, again, either a butrans patch or oxycodone MR because of his renal function. Personally, I tend to prefer patches purely because once they are at the level, it does take a couple of days for them to absorb, and you might need to use a bit more breakthrough medication in between. I probably wouldn't leave them on the codeine. Sometimes we do bridge codeine onto butrans patches, but I probably wouldn't in this circumstance because of his creatinine clearance is probably about 20 and his age. So I would probably, patches I prefer because once you get to the peak of it, it's a consistent line of analgesia, so it stays at the same level, where even with long-acting morphines, you're still going to get somewhat of a peak and then a trough associated with that. So I think in general we do prefer patches, and compliance tends to be better with patches because they put them on and they're on for a week and then they get changed. So for this patient, he's taking, in the last 24 hours, he's had about 36 to 40 milligrams of morphine. So that's morphine. So for oxycodone, you'd want to halve it. So you'd want to go for about 10 milligrams twice a day if you were going for the MR dosing. But then for a butrans patch, I think it works out to about 10 to 15 micrograms when I worked it out. But a lot of the time we tend to go lower if we can. Again, to try and help with the side effects that are associated with them. And then you need to think about your breakthrough medication. So again, you'd want to use oxycodone in this situation, but again, working at a 6th and then probably going for the lower range of it if you can. And then if they really aren't managing it that with pain, then you can titrate it up. Always make sure you put a maximum on your PRNs because again, you don't want people to be over given opiates. And again, laxatives for this patient. I'm really sorry if this whole talk has been about laxatives, but I can't stress it enough. So this one is more of a different type of pain. So he's got back pain, but when we've taken the history where the pain is radiating from the lower back down to the foot and it's worse at night time. Again, he's already on quite a lot of medication and they're managing his bowels with Laxido. His EGFR is okay. So this is neuropathic pain, and then it's really picking one of those 4 that they suggest, which is amitriptyline, duloxetine, gabapentin, and pregabalin. Ruling out duloxetine because it's not a diabetic neuropathy. It sounds more like sciatica. Amitriptyline, generally ruling out because it tends to have worse side effects in older people. So then you're left with gabapentin and pregabalin. I think gabapentin's cheaper. Check the yeah, thanks, Ryan. Check the hematinics. And yeah, because that might fix it. Very true. And then I've lost my train of thought now. Yeah, gabapentin and pregabalin. So gabapentin tends to be cheaper, so I think they like to pick that more often. And again, it's starting at the low dose and titrating upwards. But I think in particular for this is gabapentin takes a little bit of time to kick in. So it's, again, having that discussion with the patients, because the reason why we get non-compliance a lot of the time is because people expect things to work straight away and they don't. So the last one is just a little bit about probably, which might happen more out of hours, is someone with end-stage lung cancer. They've become end of life now and they aren't able to take their oral medication anymore, and it's just thinking about what you're going to do in regards to their pain medication. So this person's on regular oxycodone BD MR with 20, and they've used 20 milligrams of oxycodone IR in the last 24 hours, which again, I think probably most of you know, just from your, you guys have got a lot more experience than some of the other junior doctors, is about working out how much you've had in the 24-hour period and putting that into a syringe driver essentially, and probably not being scared that sometimes it does come out at quite high doses. If you do want to err on the side of caution a little bit, that's completely reasonable, and you could knock it down a little bit, but make sure they've got appropriate breakthrough. But for this patient, it would be putting 50 milligrams of oxycodone into a driver. If you wanted to err on the side of caution and go down to 40, just make sure that they do have the appropriate breakthrough PRN, and that's calculating a sixth of the total dose as to what they need. So sometimes with these long-standing palliative care patients who have been on opiates for longer, it's not using the 1.25 to 2.5 that they suggest on the preemptives. It's thinking about, actually, this patient's on high doses of morphine, 2.5 milligrams is not going to do anything. So you would increase the amount. And then the only thing to consider with this is what happens if they were on a 15 microgram butrans patch. Well, actually, you would just keep it there and keep it on. But if you were finding that they were needing an additional 20 milligrams every day on top of that of oxycodone immediate release, then you could add in an oxycodone driver, but just keep the butrans patch there. And it just avoids you going up on really high doses on the syringe driver. So take-home messages from this, that there are lots of things to consider before prescribing, especially in the older person. Start at low doses if possible. Think about what the mechanism of pain is, because it's going to change what you're going to pick. Avoid NSAIDs and tramadol. Is there an alternative to what we're doing? So is there something non-pharmacological, or is there something like a nerve block that could be helpful for this patient? What else you need to do when you're prescribing, so other things you might have to prescribe, which goes against the polypharmacy, but things to try and prevent those side effects, making sure there's a review date on things, and what do I maybe need to de-prescribe to help this person if I'm prescribing something new. And I can't really stress it enough, it's just review. So it's really difficult, I think, for you guys out of hours, because you kind of lose control, because you can start something, but you can't necessarily trust people to review it. So just making sure there are those review dates on Lorenzo, and even putting a stop date after 5 days if you want to. I think that's perfectly reasonable, and it makes people review it, as long as it's not a weekend, in hours. But I think it is really important to make sure that a lot of the time the problem with these patients is that they end up on them forever, and it's actually not helpful because they just get so many side effects associated with it. So that's everything. Is there any questions for that?
I have a question, Natasha. So when we're looking at the blood results, and say they've just come in, everything's fine, but we're going to prescribe them some analgesia. Looking at their LFTs, if their total bilirubin is normal, the ALT is like 165, AST is normal, would you still prescribe like 15 milligrams of codeine and paracetamol with a review date?
Yeah.
Just continue that.
Yeah. I would only, so paracetamol in particular, I'd only be worried if, the transaminases were up in the, higher than that. So, 300s maybe. And then I'd be probably doing paracetamol levels, and codeine as well. Yeah. I would only be worried if there was potentially evidence of like decompensated liver disease and cirrhosis, and maybe an acute transaminitis associated with that.
Okay, cool. And for the elderly, is there any particular laxatives that if we're giving them codeine, should we cover them with laxatives?
Yeah, so I mean, we tend to like the combination of Laxido and Senna. A lot of people give lactulose, but actually, it depends how good your older person is. So if lactulose, you have to drink like 2 liters of fluid to make lactulose effective. And if you think about, most of our elderly patients, they don't drink 2 liters of fluid, so it's not really going to work. So that's why we tend to prefer Laxido as the osmotic element. I guess opiates in particular sort of cause more sort of slowing down of the bowel. So I think Senna is important from that side of things. But then I think if you ask a palliative care physician, they love Docusate because it does a bit of both. So it's one of those things that I think most geriatricians you'll see in STH will probably prescribe Laxido and Senna. And, you can start low with the Laxido. You don't have to go high because it is a bit of a bugbear, but I know patients don't really like drinking it. A lot of the time when I'm doing ward rounds, I actually go and get an orange squash and put it in their Laxido because they seem to like it better. But yeah, Laxido and Senna are probably the two that I would go for.
Cool, thank you.
So Nikki's put a question on saying that we always seem to pick morphine over oxycodone. Should we use oxycodone more? I worry about confusion, like tramadol maybe, but maybe shouldn't. Yeah, so I wouldn't worry as much with oxycodone. I wouldn't put oxycodone in the same line as tramadol at all. I think we worry about it maybe being a stronger opiate, but as long as you're using sort of half the doses of because it's sort of half the equivalent of morphine, it should be fine. And actually, yeah, people who you're worried are at risk on that sort of AKI, threatened AKI, or you're worried that their EGFR is sort of a bit borderline and going to drop low, then I would probably pick oxycodone over morphine. I know Sarah Allison really likes oxycodone more than normal morphine sulfate for older people. But again, probably you'll find with prescribing analgesia that it's very it's quite a personal thing for geriatricians. I think different geriatricians will say different things. But we probably don't use oxycodone as much. I very much just look at the renal function for oxycodone, and I wouldn't be worried about using it. Especially in low doses, but again, you can give it and then just see, how the person can respond in hospital to it. Any other questions at all?
No questions.
Cool. I think we're probably at an hour anyway. So I hope that was helpful. I'm sorry, it was probably a bit flighty. But yeah, and next week I think we're doing delirium, which is quite a big topic. So I'll try and make it as useful for you guys as possible when you're doing things out of hours and overnight, when I know it's quite difficult about how to manage these patients. So yeah.
Thank you very much.
That's great.
No,
thanks
Tash. Thank you.
Thanks, Tash.
Thanks.